In this video we're going to look at x-raying the clavicle in several different ways. So let's pick our patient to start with. So I'm going to go into the study tab and we're going to pick a patient for a clavicle who's walking. So here's Homer Simpson in a chair, so he'd probably be able to stand up against the erect bucky, which is our normal way of doing a clavicle. It says here that he fell from step ladders and he's got pain over the clavicle, query fracture clavicle. So we'll make that selection, and we're going to, first off, we're going to do an AP projection. Okay, well, let's set the room up. So we're going to be doing an erect bucky image, so we're going to pick a receptor, 2430, and we're going to drop that on the erect bucky. The clavicle usually wouldn't need a grid, so we'll put that on the a stand outside. Sometimes with DR what you do is you actually take the grid out because the receptor's in the bucky. So you take the grid out and okay, and so we need to bring the X-ray tube over to face the erect bucky. We can do that quickly by clicking on scenario chest stand, so that will automatically move over there. Now generally speaking, the distance, the source image distance that's mentioned in the textbooks is 100 centimeters source image distance, or 40 inches for a clavicle, whereas for a chest X-ray it's about 180 centimeters or 72 inches. Now I like to leave the X-ray tube away from the bucky until we get the patient into the room and positioned, and then we can bring the tube in closer if we need to. That way you've got enough space here to manoeuvre the patient without whacking into the machine, and it doesn't seem so intimidating to the patient. So we'll leave it there for now and then bring the patient into the room. Okay, I think it's a left. Let's just go back and see. I think it's a left. Oh, it's a right clavicle. Okay, good job I checked that. So let's go back here and pick the right clavicle. So we need a right marker. So we'll put the right marker up here. That makes the point also. I've got the yellow dot at the top. I need the yellow dot at the top because we're going to have this. If the patient stood there facing us, this is going to be their right side. This is going to be their middle line. So we want the marker. I usually try and put the marker on the lateral aspect, so that's where I'm going to put the marker. So I think we're okay there. Just position that square. So I think I'm as prepared as I can be there, so I'm now going to bring our patient in. Okay, so we get our patient in and we get them to step up against the board there. Okay, so pop him up against the board and just have a quick look, see where we are with this. Okay, so we need to make sure that the midline is indeed that's probably not a good idea to shine a bright light in his face, so let's apologise and not do that. So we'll bring this tube down. I think I've got him where I want him for an AP clavicle, so what I'm going to do is I'm just going to bring the machine in to 100 centimeters. Obviously I'd be warning him about this. Bring it down. I'm just going to make sure I'm not shining it in his eyes, and then turn the light on and collimate. Okay, so we're aiming for the clavicle here. He's got his shoulders a bit sort of hunched up, so the clavicle is down low and up high here. It's more on a sort of diagonal. So we've got to make sure we know about that. It depends on whether they're very badly injured or whether they've sort of particularly tensed up, whether or not they're going to have their shoulders hunched up like this. I'm fairly sure, because I can see that I'm centering in the midline here, and I can see that my collimation is on this side within the collimation of the receptor, that it will be within the collimation of the receptor on this side. This is the importance of this middle check here. So now I'm fairly confident that because I've got the point of the shoulder on and I've got the sternoclavic on there, I can just bring it in a little bit more, but I'm fairly confident I've got the entire clavicle on there. So I'm just going to collimate in a little bit more, because there's no need to be any more than that, and I'm going to pop the marker up here so there's no chance of it sitting over any anatomy that I might need. Okay, so happy with that. So I'll give the patient some instructions, tell them what I'm going to do whilst I go behind the screen. And this, we would just see arrested respiration, so we'd just say to stop breathing rather than breathing in, because if they breathe in violently then they'll move, so we don't want them to do that. So the clavicle, because it's got a well, we'll talk about that after we've exposed it. I'm going to hover over the exposure button now and expose. And we'll flip this over and window. Okay, so the point of using a high tube voltage is that the clavicle has got very little material covering the lateral aspect, so the X-rays will easily penetrate the lateral aspect, and it's got quite a dense area to be covered when we look at the medial aspect. So we have to go through quite a lot of material to get through the medial aspect here. So it's quite a tricky area to get an image of with the correct contrast throughout. And so one of the ways that's suggested is to use a high tube voltage so that we even out the contrasts. I'm struggling to get decent quality here because I think the scatter fraction is pretty high. Yeah, the scatter fraction is 60%. So what I'm going to do is I'm going to pop this in the grid. Generally speaking, I think most machines wouldn't need this, but we're going to pop this in the grid and we're going to expose this again. And then I'm going to use the rule of thumb, which is add 5 kV and double the MAS. And then expose that for a grid exposure. Okay. So that's now giving me better image quality because the scatter fraction is reduced. So I can now, it's still going to be difficult to see all the way along the line, but I can trace the bony outline all the way around. So now we're going to look at how else we can X-ray this image. So the next, according to the book, the next way to look at this, because we want to see the clavicle in 2 different projections, so the next way to look at this is to actually angle up. So what we're going to do is we'll do a 15 degree, so that means 105 degrees. So that's 15 degrees angled up, and drop the tube down and bring the tube in because we need to stick at 100 centimeters. Source image distance 40 inches, and then collimate and raise the tube to within. Everything else remains the same. We're in the mid-clavicular line. Okay. Clicking the wrong button there. So what we're looking at here now is an angled projection. So we're projecting the clavicle so it looks a bit straighter. Instead of being S-shaped, it's now slightly straighter. And we're seeing it from a slightly different angle. Okay, so there are 2 reasonable projections of the clavicle, and they're the ones that are quite commonly referred to in the textbooks. It's still not a great difference in alignment, but it is a difference. You can see there's a gap here. You can see the acromion and the scapula there. Okay, so let's try a larger angle. So the books talk about 15 degrees to 30 degrees as an angle that's applicable. So let's try, that was 15 degrees, let's try 20 degrees. We'll try 25 degrees, so that's 115 degrees. So I'll drop that down. I've shone it in his eyes again, which is never a good thing. and bring the tube in. Raise it up. So again, we're trying to go mid-clavicular line and include the medial aspect. And this time I think there will be some discontinuity. Yeah, so now we're centering. We need to raise the bucky up higher than it appeared we needed to. We're also practicing to make sure, do not move the patient once you've you keep the patient in the same place, because you want to, I'm moving the X-ray tube out to see how it lines up with the bucky, and then moving it back and it locks in place, so it's now centered to the middle of the bucky. So that's good. So we'll have a look at this now. So this is 25 degrees. So now this is a very different projection of the clavicle compared to the AP. The AP, we were getting quite an S shape, and now we're getting a very straight clavicle. Particularly good for the lateral aspect here. So that's 25 degrees, quite nice. Okay, so what other projections are there? What other techniques are written in the books? Well, the advantage of the AP projection is that you can actually see the clavicle, and the patient is putting their back to the board, and patients always like to be able to see out around themselves and see the surroundings, and they're not so keen on facing the board and not knowing what you're doing behind them. But the disadvantage is that you're a long way, the clavicle is a long way from the receptor, so there's some magnification, distortion involved, and also the structures that are anterior in the patient's body are more radiosensitive. So the high intensity of the X-rays is facing the most radiosensitive organs of the body, which would be the thyroid and the breast tissue in this case. So there is an advantage to X-raying the patient posterior anterior. Those two advantages are the clavicle's closer to the receptor, and the less radiosensitive organs of the body are going to take the highest radiation incidence. Okay, so what we can do is see what the difference looks like with a PA clavicle. Of course, we have to face the negatives, which is we can't actually see the clavicle, so we need to know some surface markings posteriorly, which will equate to the clavicles. So I mean, usually it's about an inch lateral to the medial border of scapula, but I would tend to just look for the point of the shoulder and make sure we include that, and the spine as process. Make sure we have the spine as process, which will allow us to get the medial end of the clavicle on. Okay, so I'm happy with that. I'm now going to have to put my marker on, posterior anterior marker, and pop that over in this position and close the bucky tray. Okay, so everything else being equal, we're going to try a PA clavicle. Okay, so I'm just going to go back in here and change this to a PA, and we'll fire down the I think it was something like 75 and 5, and expose that. Moving this way this time. We've already got a much nicer image because we've got no what's called geometric unsharpness, which is where if the receptor, if the object that we're looking at is further away, then it gets blurred. The boundaries of that receptor may get blurred by the time they're projected onto the screen. So I'm just trying to get an equal. So this is the AP image, and this is the PA image. So certainly you can see there's a lot less magnification because this is a lot narrower than this. So I think the PA is actually a nicer image of the clavicle. Now we'll try the it's called a half axial projection, but the angled projection. We all know that axial means for it to be an axial projection, then the receptor would have to be in the axial plane, and it isn't. It's in the coronal plane here, or parallel to the patient's coronal plane, I should say. Because we angled up when the patient was antero-posterior, we're going to have to angle down now the patient is postero-anterior. So where it was 90, it's going to be 65 now. It's for 25 degrees. Okay, so raise this up and see if we can aim at the clavicle. So the image quality was good last time, and I didn't find it particularly difficult to center, although so those two downsides weren't too bad, he says, hoping that he hasn't missed the clavicle off this time. No, hasn't missed the clavicle off. Got a really nice acromioclavicular joint here, and I've got a nice straight clavicle. And if I compare that with the 25 degree AP projection, I think this is looking better compared to the 25 degree AP clavicle. So PA has got some real benefits in terms of image quality and radiation dose. The only negative really is whether or not the patient will be tolerant of it, because then facing away from you, and it's certainly for patients who are hard of hearing and things like that, it's more difficult because they might be relying on lip reading and things. So there are some negatives, but generally speaking there's quite a lot of positives from doing PA clavicles. Just remember to reverse the angle and angle down instead of up if you're doing a PA clavicle. Okay, what about the patient who has fallen like our decorator friend here, but is actually too ill to stand? Let's see what are the options there. So we'll get our patient in and pick a patient who might be too ill to stand. So here we have. Let's try and find a female patient. Well, actually, we'll X-ray Ned on a trolley for a clavicle. Okay, so this is a rugby referee caught between tackling players. Deformity and tenderness over right clavicle, unable to bear right leg, query fracture clavicle, query fracture tib and fib. So he's not going to be able to stand up for us because he's also querying a fracture of his tib and fib. So what we'll do is we'll just X-ray his clavicle, and instead of being erect, well, it doesn't have an option for him not to be erect. So we're going to have to do something, make something up. Okay, so we'll go to here. I'll just move the X-ray tube out of the way. So we'll just move it over here somewhere until it's out of the way, and then we'll bring the patient into the room. Okay, so it's been brought in on a stretcher, and then we've got to position him for his imaging. So what I'm going to do is I'm going to turn this round, pop him there. Okay, so we could do the standard projection, which we've just done. AP, of course, we can't do the PA one. So we'd have to resort back to an AP clavicle with the patient on the trolley. Now, the problem you've got is that you wouldn't want to raise his shoulder up here to put a plate under here, because that would be quite sore, and getting him to rotate onto one side, he's clearly damaged his leg as well, you know, so he's in a bit of a bad way. So this is where we would use this tray. So we're going to pop our receptor, and we'll put a grid receptor on here. Well, will we? This is the question. So we can use a grid receptor for the AP because we still want the grid to line up in what we call portrait mode, because the clavicle is longer than it is high, isn't it? So we want to be able to put the receptor in this orientation. However, the line on this grid receptor indicates the grid lines. So with the erect bucky, the grid lines are travelling up and down. So it was easy for us to angle up or angle down, and the X-rays would still have lined up with the grid lines, so we didn't have a problem. But here, because the grids historically always go the long axis of the receptor, then we can't angle against this grid. If I was to angle in this direction, then what will happen is we'll get grid cut off, because we're angling against the little slats of lead that make up the grid, and the X-rays wouldn't get through. So we can't angle in that direction. So we could use it in this way to X-ray our AP clavicle, which we will do. So just move over here and move across. Of course, grids these days are becoming less and less needed because the image quality, the algorithms that software manufacturers are developing are able to compensate for scatter much better than they ever did. So the use of a grid receptor is becoming less and less important, which is a good thing. So those of you who do need to use a grid or do need to know how a grid works. Now I can move the tray along. I can move the tray along on this sliders here by clicking on the blue, and then I can also move the tray in and out by clicking on the tray itself. So I just have to by eye line up things to make sure that I'm getting the medial end of the clavicle on and the lateral end of the clavicle on. So I'm fairly happy with that. So we'll leave it like that. Just put a marker on. And tick. And see where we are from there. So I'm going to call this an AP clavicle. And we'll drop this down to something like 4. And expose that. That's quite nice actually for an AP clavicle. So very nice image there. So now it's a question of how we get the angled projection. So we can't angle against the grid with our 15 degrees. 25 degrees we're going to go for. If I do that, F, move it across here. And then bring this up to meet it, and bring this across. This is one option. And bring that across again. But I can't do that because I'll get grid cut off. I'll just show you what happens. If I expose that, I'm going to get grid cut off because my X-rays are now not parallel to the grid lines. They're now angled against the grid lines, and so they'll be blocked. Basically, the grid is acting as if the primary beam is scatter, and so it's being rejected, it's being absorbed. Okay, so what we've got to do, if we were going to use we could use a non-grid receptor, which is fairly common anyway for a clavicle. So one of those areas where the body which may or may not need a grid, depending on how muscly the patient is. Okay, and how good the algorithm is for removing, for analysing the image. Okay, so there you go. So there's the non-grid image, which is reasonable, but still fairly scattery. We could collimate a bit more, I suppose, which would help. Or the other alternative is to use a large receptor. So we can use a larger receptor, put the marker here, and this is now a grid, but the grid line is now in line with the angle, so it should be fine. And we expose that. And now we have our clavicle and our AP clavicle. Well, not our grid cutoff clavicle, but our AP clavicle. There you go. So this is obviously going to look smaller because it's the whole image is being shown instead of here. But you could, on systems, clinical systems, you'll be able to zoom in on this to look at it in more detail. Okay, let's just show you the final way of doing X-raying the clavicle, which is an actual axial projection. So what you can do is you can pick the 3543 grid cassette and you can pop it, not in his head, but you can pop it against his shoulder there. Okay, and then what we can do is angle the tube even more. And what we're doing now is, because this is now in the axial plane, it is a true axial projection. And what we're doing is we're actually projecting the clavicle up onto the receptor. So let's see what image we will get if we do this. Okay. So you can see we're really seeing under the clavicle here, but we're only seeing the lateral aspect of the clavicle. And we can see the coracoid process as well. So this is an axial clavicle, and it has been used in the past to get images of even more radical image to see whether there's any forward or backward, anterior posterior shift to the fracture. So you can see this is the AP clavicle, and you can see the coracoid process is effectively coming towards us, and this is the axial clavicle. You can see the coracoid process pointing straight up. So we're definitely seeing almost a 90-degree projection. So I'll leave you with the Ponsford and Clements axial clavicle.